bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, and the Children's Hospital Foundation of Saskatchewan. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the Ken to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Paediatric Health Centres. And today's webinar is titled Changes in the Incidence and Surgical Treatment of Ankyloglossia in Canada. And it's my pleasure to welcome Dr. K.S. Joseph to the CAFC Presents stage today. Dr. Joseph is one of a group of researchers who have been named as research chairs in maternal, fetal, and infant health services research by the Canadian Institute of Health Research. And CAFC has been honored to be a knowledge translation partner with CIHR in that Canada Research Chairs program. We've already brought a number of other individuals from that group, including Dr. Prakash Shah, who talked about networks in neonatal intensive care, Dr. Alison McPherson talking about childhood injury, Dr. Roberta Woodgate presented a few months ago and is also actually coming back in a couple months. So it's my pleasure to welcome one more member from that group of research chairs, Dr. Joseph, today. Dr. Joseph is a professor in the departments of obstetrics and gynecology and the School of Population and Public Health at the University of British Columbia and the Children and Women's Hospital and Health Centre of British Columbia. His work is supported by the BC Children's Hospital Research Institute, and his research interests include pregnancy, complications, birth, fetal growth, infant mortality, serious neonatal morbidity, and severe maternal morbidity. So it's my pleasure to welcome Dr. Joseph to the CAFC Presents stage. But before we hand the virtual podium over to Dr. Joseph, we just wanted to ask the audience a quick poll question that you can now see up on your screen. This is your opportunity to just have a look at the question and select your answer by clicking on the screen. But the question is, do you believe that routine frenotomy for ankyloglossia in newborns is efficacious for breastfeeding problems? Just yes, no, or not sure. So we'll just give everyone a chance to make their selection. There's probably still a few people that are connecting their lines and getting their audio in. But when you do get connected, just make your selection on the screen. We've got a few more seconds that we'll let people put in their response. But do you believe that routine frenotomy for ankyloglossia in newborns is efficacious for breastfeeding problems? Yes, no, or not sure? All right, so we'll close that off and we'll look at what the audience says. It looks like a pretty split, almost a third of each, 34% saying yes. It is efficacious, 36% saying no, and 31% not sure. So I guess if you're not sure, you're in the right place, because we're going to hear a little bit more about it. So without any further ado, it's my pleasure to hand the virtual podium over to Dr. K.S. Joseph. Over to you.
Thanks, Doug. Thanks, Anne. So as Doug mentioned, I'm going to discuss how the frequency of this particular congenital anomaly, ankyloglossia, has increased in Canada and how its treatment has changed over the last decade or more. Before I begin, just to give you some background to this assessment, I used to work for the for the Perinatal Services BC, a reproductive care organization in British Columbia a few years ago, and they have a public health surveillance obligation, including, that there is a need to identify unexpected increases in congenital anomalies, to evaluate the effects of interventions on congenital anomalies For instance, we've had this food fortification with folic acid for some years now. What effect has that had on neural tube defects and other congenital anomalies? And of course, to keep the public informed by dispelling any myths. And the fact is that we do collect information on congenital anomalies routinely, so looking at it is important. And I undertook one of these projects some years ago, and I'm going to just talk about Ankyloglossia as the issue that came up. But before I go there, just to give you a sense of why it's important to look at temporal trends in congenital anomalies, these are some very famous graphs which you may or may not be familiar with. So it's like the x-axis seems to give you years, 1957 to 62, and then there is some kind of count on the y-axis, and you can see two curves, one with the dotted line and one with the solid line. And I'm not sure you can recognize them, but in fact, these are curves showing you the frequency of thalidomide sales as they peaked in Germany. That's the dotted line. And then following that, in a couple of 10 months later or whatever, with a lag period, you can see the rise in the incidence of cases of phocomelia, which were caused by the thalidomide. Canada unfortunately had an experience with thalidomide. In 1961-62, we recorded 115 cases of this particular devastating congenital malformation, and you may be aware that this issue is in fact playing out in Parliament, and with the compensation being awarded late to the victims of this tragedy. Here's the timeline. In late '59 in Canada, thalidomide became available as samples that physicians could use, and in April '61 it was licensed for prescription use. In December '61, thalidomide was withdrawn from West Germany and the UK. Interestingly, it was a clinician who did not do any study, but who made the connection between use of thalidomide in pregnancy and the congenital malformation that followed. There were two people who discovered it simultaneously, the effect of thalidomide. So in March 1962, the drug was withdrawn from Canada, but in May, it was still available in some pharmacies. And so we had over 100 cases in Canada. Interestingly, this drug was never licensed in the United States thanks to a Canadian, Dr. Francis Kelsey, who worked for the FDA at that time. And in that old photograph you can see on your screen, she's being honored at the White House by President Kennedy for saving the United States from this pharmaceutical disaster. So, as I mentioned, surveillance of congenital anomalies is a obligation that Perinatal Services BC had, and so we used the British Columbia's Perinatal Data Registry to look at all malformations and their trends in British Columbia. And the database they have includes all births in British Columbia, including home births, and the analysis included all live births from April 2004 to March 2013. And Ankyloglossia was identified using an ICD-10 code Q381, and frenotomy, the surgery that's done to address this issue, was identified using a CCI, a Canadian Classification of Interventions code that's listed on your screen. So the temporal trends in various congenital anomalies were examined, and most of the patterns were as expected, except there was a sustained increase in ankyloglossia, the tongue tie, and you can see it if you're not familiar with that term, you will understand the term tongue tie, and you can see a picture of a little baby with the lingual frenulum, which is thickened. So the formal definition is a minor congenital anomaly characterized by a short, thickened, or abnormally trite lingual frenulum, which may result in varying degrees of decreased tongue movement. So when I first saw this, I thought it was an incidental finding and of no significance. And I did not investigate it further, and there were some other interesting findings in the analysis that I had done. So when I presented it at a local conference here in Vancouver, it was pointed out to me by a hospital manager administrator from Quebec, actually, and she told me, that it's linked to breastfeeding issues. So that's where this whole story began. So we actually ended up publishing our results of temporal trends in ankyloglossia and frenotomy in British Columbia in the CMAJ Open Journal. And the analysis included about 450,000 live births, of which in 3,000 cases, 3,000 babies, there was this diagnosis of ankyloglossia made, giving you a birth prevalence of 6.6 cases per 1,000 live births. And there were about 1,700 frenotomy procedures done, giving a rate of 3.8 per 1,000 live births. Here you can see the temporal trend graphed on the x-axis. You have the years from 2004 to 2013 and the rate per 1,000 live births on the y-axis. There's a steady increase in ankyloglossia and there's a steady increase in frenotomy. All these temporal increases are highly significant statistically. I haven't bothered to show you the p-values, but since I'm dealing with extremely large numbers, all these trends are highly significant. In this graph, you can see over time the change in the rate of frenotomy per 100 cases of ankyloglossia. So not only is the rate of ankyloglossia increasing among babies who have ankyloglossia, we are doing more frenotomies. If the diagnosis is made, we are more likely to do a frenotomy today than in the past. The rate was as low as 55% in 2007, and you can see by 2013 we are performing this minor neonatal surgical procedure on about 64-65% of babies. We also looked at the risk factors for ankyloglossia using a multivariable analysis, logistic regression. And so you can see here the associations with age and ankyloglossia and parity as well. So for instance, nulliparous women compared to women who are multiparous, the nullipara their babies have a 47% higher risk of having ankyloglossia compared to the multiparous women. Similarly, if you look at body mass index, women who have a body mass index greater than 30 are about 14% more likely to have the condition, their babies to have the condition compared to babies of mothers who have a BMI between 18 and 24. Multiple babies born of multifetal pregnancy are protected against ankyloglossia. They have about a 32% lower risk of the diagnosis compared to singleton babies. Male babies have a higher risk, a 74% higher risk compared to female babies, and larger babies 4,000 to 4,499 grams have a 26% increased risk, while those 4,500 grams and over have a 39% increase in risk of ankyloglossia. We were interested in this relationship between breast milk feeding and ankyloglossia frenotomy rates. And so here in this graph, you can see on the x-axis, we have plotted the percent of infants who were breast milk fed. And on the y-axis, you have the rate of ankyloglossia and frenotomy per 1,000 live births. And so you can see a fairly tight correlation. I think the correlation coefficients are in the region of 0.9. So quite a good correlation between these two conditions and breast milk fed babies. But what is important to know is that the range of breast milk feeding is very narrow. It goes only from 93 to 95%. So these data points, you have them by year, and you can see that we don't have much of a variation in the rate of infants who are breast milk fed. There was substantial variation, regional variation in ankyloglossia and frenotomy rates. And here you can see the rates by our health authority. So we have the lowest rates in the interior and Vancouver Coastal Health Authority, whereas we have some high rates in other health authorities, both in ankyloglossia and frenotomy. The rates are between the lowest and the highest. You can have as much as a threefold variation in rates of ankyloglossia and frenotomy. So we, of course, asked the question, what's the situation like in Canada? And so we turned to a different data source, and this was the discharge abstract database of CAIHI, which you all must be familiar with. It includes live births, all hospitalized live births, excluding those from Quebec, because Quebec maintains a different database which we did not have access to. And the data spanned the period from April 2002 to March 2015. And we use the same Ankyloglossia ICD code and the same CCI frenotomy code to identify these conditions. And we have put together a paper. I've listed the names of the co-authors on that paper, and this was done through collaboration with the Public Health Agency of Canada. And we were looking at some 3 million live births, of whom 40,000 had a diagnosis of ankyloglossia. That gave us a birth prevalence of 11 per 1,000 live births. Of these, some 24,000 babies had frenotomy. That gave a rate of 6.9 per 1,000 live births. Here's the trend in ankyloglossia and frenotomy between 2002 and 2014. You can see that there was a steady increase, which has sort of become the rate of increase has picked up in the most recent years, around 2011, 12, and beyond. The curve has become much sharper upwards. So in terms of numbers itself, the rate of ankyloglossia was about 6.9 in 2002, and it has increased to threefold to about 22.6 in 2014. Frenotomy has gone from 3.8 per 1,000 to 14.7 per 1,000. And among infants with ankyloglossia, frenotomy rates have, just like in British Columbia, they've increased from about 55% to 64%. All these changes are highly significant statistically. Looking at the rates in each of the provinces, the temporal trends in each of the provinces, these are the provinces with relatively lower rates, but they are rising as well. There's an increase in every province or territory. So you can see there, going from the bottom to the top, the labels, there's Nunavut with the dark circles, there's Newfoundland with the dark diamonds, there's New Brunswick, Ontario, Prince Edward Islands, Manitoba, and BC. So in fact, British Columbia, although that was what we looked at first, has one of the lowest rising trends. In this next slide, you'll see the provinces with much higher rates. And so this scale, the previous scale went up to, I think, about 25, but this one goes all the way to 60. So you can see that in provinces like the Nova Scotia, which was actually having a low rate, has suddenly had this dramatic increase in the diagnosis of ankyloglossia starting from about 2013, and then there's a really high rate in 2014. Saskatchewan, Alberta, and the Yukon also have fairly high rates between around 40 per 1,000 live births. So the regional variation in frenotomy, lowest versus highest. So the low provinces are, and this is for the period 2012 to 14, the low provinces with low rates, provinces and territories are Newfoundland and Labrador, Nunavut, and British Columbia with rates around 1 to 6, whereas the higher rates are seen in the Yukon, Alberta, and Saskatchewan in the low 20s. In 2014, the highest rates were in Saskatchewan, Alberta, and in Nova Scotia, the rate of frenotomy was 42 per 1,000, which is a 4% rate. So the discussion on these issues, very briefly, I'm not an expert on ankyloglossia and frenotomy. As I mentioned, my interest in this condition arises more from a surveillance of a congenital anomaly perspective, rather than I neither understand the clinical condition nor am I an expert on breastfeeding issues. So there's been this rapid temporal increase in rates of ankyloglossia and frenotomy in Canada from 2002 to 2014, and there's tremendous regional variation. The trends appear to be accelerating, and currently we have frenotomy rates of 3 to 4%. So 3 to 4% of our babies are receiving a minor surgical procedure in the newborn admission. The overall rate in Canada was 11.2 per 1,000 live births. In fact, the rate in research studies is much higher. It's 4%. And that the various research studies document rates ranging from less than 1% all the way to 11%. And the fact that in our study the rate was so much lower, that's because in the childbirth admission, this diagnosis is only made when it is symptom prompted. It's not that we're routinely looking into every baby's mouth to check for this particular condition. So also, there's no consensus on the definition and the diagnostic criteria for ankyloglossia. And so it's variable whether this diagnosis is made or not. It's most likely to be made if someone looks in the mouth after being prompted about feeding difficulties. If we have better tools, and there have been recent attempts at standardizing the diagnosis of ankyloglossia, but those new tools have yet to be validated. So the reasons for the increase in ankyloglossia, it could be that we have this increased emphasis on breastfeeding initiation before discharging moms and babies from hospitals, especially because of the baby-friendly hospital initiative. So that could be giving rise to what may be called a surveillance or detection bias. So we are looking more closely and therefore we are finding this condition. Or it could be that it's just earlier diagnosis and treatment. In the former, we are saying that this is an artifact. In the second explanation, we're saying it's not an artifact, this is a real thing. So it's not exactly clear which of these two explanations is the correct explanation, but there is a tendency for my co-authors and myself. We think perhaps that the diagnostic uncertainty, the large regional differences, and the push for breastfeeding suggests that this may be a surveillance bias. We are looking so closely and finding problems issues that may not be as significant, but we don't know. So the Canadian Paediatric Society discourages routine surgery for ankyloglossia. They brought out two guidelines, one in 2011 and another reiteration in 2014, saying that frenotomy for ankyloglossia was not recommended for newborns. In 2015, they modified that recommendation slightly, and they said it was not recommended routinely for all cases, but that there was potential for benefit in cases with significant breastfeeding difficulties. Across the world, the status of frenotomy for ankyloglossia, there's no consensus on this issue. The Dutch and the Japanese pediatric societies do not endorse frenotomy. On the other hand, in the UK, under the UNICEF's baby-friendly hospital initiative and the American Academy of Pediatrics, they recommended for symptomatic ankyloglossia. So we have a state of clinical equipoise with our clinical community split regarding the need for frenotomy given ankyloglossia. And there's a lack of and this is because there's a lack of good quality evidence on the efficacy of frenotomy for problems related to breastfeeding. The lack of evidence is summarized by the statement that randomized trials to date, they've all been relatively small, or most have been relatively small, and they are plagued by methodologic problems like the randomized trial did not include blinding, the outcomes were subjectively defined, and which makes it a particular problem when you don't have blinding. A recent systematic review by Francis and others, which was published in Pediatrics last year, they concluded that with small short-term studies with inconsistent methodology, the strength of the evidence for frenotomy is low to insufficient. Frenotomy for breastfeeding difficulties is low to insufficient. So people have framed this controversy between the need for frenotomy given ankyloglossia or viewing it as an unnecessary procedure. That conflict has been framed as being something, the opposition between lactation nurses, breastfeeding support groups, and mothers facing breastfeeding problems versus pediatricians who question the efficacy of frenotomy. Surveys of lactation consultants show that 30% believe that ankyloglossia causes feeding problems occasionally, and 69% say that frequently or always ankyloglossia leads to breastfeeding difficulties. On the other hand, surveys of pediatricians show that 90% of them believe that ankyloglossia rarely or never causes feeding problems. So in conclusion, there seems to be, there is a strong desire to increase breastfeeding initiation rates across Canada. Unfortunately, there are no standardized criteria for the diagnosis of ankyloglossia, and there is a lack of evidence favoring frenotomy in this situation. The bottom line is we now have a contentious situation with runaway rates and huge regional variation in rates of ankyloglossia and frenotomy in Canada. And what we need are high-quality randomized trials to resolve this problem in what may be unnecessary surgery for newborn infants. So my acknowledgements, my co-authors for the BC study, Brooke, Amy, Neda, Yasser, and Saka, and for the Canadian study, Michelle, Shilang, Susie, and Aideen. Thank you. I'm happy to discuss this further if you have any questions.
So before we get into the questions, and this is my chance to remind everyone, if you do have a question, please type it into the question box whenever you think of a question. We are going to do another poll again. Just based on what we've just heard, we're going to ask that same question. Once again, maybe your response from earlier in the presentation has changed, but we just want to see if there's been any change in how you think about frenotomy and ankyloglossia. So do you now believe routine frenotomy for ankyloglossia in newborns is efficacious for breastfeeding problems? So now that you've heard some evidence, some of the data, has your opinion changed? So just go ahead and make a selection on the screen, and once you've made that selection, please do start typing your questions into the question box. All right, so we'll close that off, and we certainly have seen a bit of a change. The not sure, it was almost 30%, 30%, and 30% at the beginning. We've now seen the not sure group fall from about 30% down to 19%, and that the no group, that they do not believe it's efficacious for breastfeeding problems, is increased to about 40%, 46%, and the group that does believe frenotomy for ankyloglossia is efficacious for breastfeeding problems has stayed about the same at 35%. So I'm not sure, Dr. Joseph, any thoughts on how your presentation has changed that, how the results of that survey?
I think it's very informative and interesting to see these results, and I think my take on this would be that we really have what's called equipoise, a situation where the community is divided, and like approximately half the community believes the thoughts go in one direction, whereas the other half goes in the other direction, and so this is the kind of situation where really we can ethically do a randomized trial to offer one arm of the randomized trial, say frenotomy, and the other half of the randomized trial, a procedure which effectively blinds them but is not frenotomy. And so in order to assess the effect of frenotomy, we have a perfect situation in Canada to carry out a randomized trial. So that would be my take from the way the poll has come. There's been a small change, I agree, but I think that, for instance, if you look at the 1/3 of people who said yes to the question initially, that the fact that it's unchanged, those people are probably frontline clinicians whose conviction is strong, so that's why they haven't changed. It's probably the not sures who have moved to the no. So my take would be that we still have a contentious situation, and it is a perfect situation for carrying out a randomized trial to assess to find out, in fact, if it's efficacious or not.
All right. So we do have a number of questions that are coming in now. Mona was asking, so you had mentioned that one of the issues is the lack of clear diagnostic criteria for ankyloglossia. She's asking, did you review the Hazel-Baker tool for tongue tie assessment?
No, I mean, like I said, I'm not an expert in this area. There are a few tools I know existing, and even very recently there's been a new one published. So these tools, my understanding is that the fact that new tools are coming up and the fact that the newest ones haven't been validated means that we still are in a position of some uncertainty. But if if she has had particular experience with this, I imagine she's saying that may be a reasonable tool to use.
All right. The next question was from Louise, and she's asking the rates of frenotomy that were presented in the provincial data that you presented. Was that from in-hospital data only, or was that both in-hospital and outpatient procedures?
Yes, indeed. That's an excellent question. The data that I presented was from the birth admission only. So just that first birth admission. If they were subsequently readmitted, that information is not there. And if there was ankyloglossia done outpatient after they left hospital or later during their infancy, that's not included. So these are increases and regional variation in the birth admission, the first couple of days after the baby is born.
All right. Anne is asking, she says, thank you for the presentation. And then she says, have you looked to see if there is a correlation between breastfeeding rates and incidence of diagnosis and treatment of tongue tie? You did put up a graph that sort of talked about breastfeeding rates, but I'm not sure if that specifically was a correlation between breastfeeding rates and diagnosis and treatment.
Yes, so that indeed was the graph. So in British Columbia, the database includes information on breastfeeding, and the particular issue, or the particular measure that we used was not just breastfeeding, but breast milk feeding, meaning irrespective of how the baby was being offered breast milk, whether breast milk normally or through the bottle or in any other way. So there was a strong correlation, but the range in our data was very, very small. So the range was only between 93. Our breastfeeding initiation rates are very high in BC hospitals, so it's going between 93 and 95%. So it's a very, it's not clear. It's not at all clear. I don't think you can draw any causal conclusions from that. It could be, for instance, that one way to argue, interpret that correlation would be to say that in that very narrow range, the diagnosis of ankyloglossia improves breastfeeding. So the higher the rate of ankyloglossia and frenotomy, the higher the rate of breastfeeding. Alternatively, you could say that the hospitals where the breastfeeding rates are slightly higher, where there is a much more organized clinical push to have breastfeeding initiation, there the people are also doing ankyloglossia, making diagnoses of ankyloglossia and carrying out frenotomy. So there's a reverse causality issue there, because this is a cross-sectional study. We can't make that conclusion, we can't make a firm conclusion as to what is causing what.
Mm-hmm. All right. The next question that comes in is just asking, what do you mean when you use the term routine frenotomy? I'm assuming that's doing a frenotomy in the presence of ankyloglossia, but in the absence of symptoms?
Yeah. So the Canadian Paediatric Society says significant breastfeeding problems. In the face of significant breastfeeding problems, ankyloglossia warrants frenotomy. Routine means you see it and you do it.
Okay. We did have a fairly long comment put in by that Mona has contributed here, so I'll just read this off. She says, in her area, when there are breastfeeding difficulties, the pediatricians and family docs send the babies to the breastfeeding clinic for assessment by a lactation consultant. There are assessment criteria of nipple shape when babies unlatch and damaged nipples that show that when the tongue tie is impacting breastfeeding, as well as ultrasound studies that show suckling dynamics. So could the normal suckling pattern be compared to suckling dynamics that are not effective? Therefore, she would argue that asking a physician who does not know the assessment criteria for when tongue tie impacts breastfeeding would then not be able to determine if it actually has an impact on breastfeeding. So again, you not being a clinician, as you said, I'm just not sure if there's anything you can comment there. I mean, we're really trying to determine whether it's the tongue tie that's in fact impacting the breastfeeding.
Indeed. So we are in a situation where we do not have enough information as to on either side. So if you believe that it's the randomized trial that will give you the ideal answer to this particular question, we don't have. But on either side, you could have opinions based on various modalities. So, and like you said, I mean, the person who's asking the question here may have a lot of experience in this particular area, and so she may have a greater basis for forwarding one side of the issue, or arguing for one side of the issue. And maybe a pediatrician or whoever is on the opposite side may have other reasons. But in fact, what the world is waiting for is for a couple of well-done randomized trials, which are, at least in the research world, considered the gold standard for assessing the efficacy of any drug or treatment like frenotomy. So until we have that, there will be some contention about what is the most efficacious, if frenotomy is in fact efficacious or not.
The next question that is asking about breastfeeding versus breast milk, sort of from that perspective. She says, do you think that breast milk feeding is an accurate statistic to report when breast milk feeding includes pumped breast milk fed by a bottle? And suggesting that typically bottle feeding, in their experience, is less affected by the ankyloglossia.
Yeah. I mean, it could, maybe we could have looked at our correlation with breastfeeding, but I personally, knowing the number, having seen some of the numbers in British Columbia, I don't think the correlation would have changed much. But perhaps we should have also looked at the correlation between breastfeeding and the rates of ankyloglossia.
So the next question, again, this is another one that's fairly long. She says, Jennifer says, there certainly is a lot of controversy around this. She says her difficulty is with older children who continue to have speech difficulties and or feeding issues who had unrevised ankyloglossia. She says it's hard to convince family doctors to refer to ENT for evaluation and possible revision, as they currently think there is no connection between this and the speech delay, especially if they have completed a very thorough exam and feel it absolutely is connected. She says it's frustrating as experienced by an SLP, a speech and language pathologist. Do you foresee any movement of your research impacting physician training and practice?
Oh, yes. So I did, in my reading of the literature, my understanding is that this is a completely different issue. So when you have in toddlers and older children, if you have speech impediments and problems, and there is an ankyloglossia associated with that, the status on how to treat that is different, and there are clearer guidelines there. And I think that I can understand the questioner's frustration that some family physicians are being reluctant to refer, but I think that issue is completely different from the issue we are discussing now, because that's been a well-recognized issue that in some small fraction of children where there is speech or other impediments because of the reduced mobility of the tongue, their treatment is advised.
There's lots of questions. I won't go through them individually, sort of talking about in many cases, the ankyloglossia is not noticed until after discharge, and it's identified out in the community, etc. So Sonia in particular is saying many cases of ankyloglossia are caught in the community, and she would hope further studies would aim to catch both in those noticed in hospital and out in the community. She also suggests that we need to study the impact of lip tie and how to define and how to determine when, in fact, there are breastfeeding issues that may be tied to either ankyloglossia or lip tie or anything else.
Yeah. It looks like an emerging area for research. And so the two things that we need to do is, first, we need to standardize diagnosis of ankyloglossia. So what are the criteria when we will make the diagnosis? It's not just it should not be just a subjective impression. So if we do have a validated measure, then we could even institute a routine look into the baby's mouth soon after it's born to check whether there is ankyloglossia according to some standardized criteria, yes or no. And then that may obviate this particular issue of cases being missed at birth. Then the second issue is the issue of the efficacy of frenotomy. In that context, I just want to say that when a treatment is given or a surgical procedure is done, there is a substantial subjective improvement that's noted that has nothing to do with the procedure itself, but it's more a psychological phenomenon, and that's what we need to assess through a blinded randomized trial. The paradigm for this is in the late 50s. There was a procedure which was recommended for ischemic heart disease, for chest pain and angina, which involved the opening the chest and diverting the internal mammary artery into the cardiac myocardium, where it was not that the blood vessels were being ligated to each other, were being sutured together so that blood flow was flowing from the internal mammary into the cardiac coronary vessels. It was just fusing the internal mammary artery into the muscle, which today we would recognize has no meaning. It would not do anything. But at that time, it was a fairly standard procedure. And when the first randomized trial was done on this, published in 1959 in the New England Journal of Medicine, it showed that the treatment, in fact, had no effect, and so the treatment has been abandoned since. But what was interesting was that the people who had the surgery, which involved their chest being opened, they, post-surgery, the ones with the chest pain, they reported 30% of them reported a substantial improvement in chest pain. So that's why we need the blinding. If you do a surgical procedure for the little baby, and if the mother subjectively reports an improvement in breastfeeding, it needs to be assessed with a blinded control group as well. And only then can you really say it's efficacious. So that's the issue why we need a blinded, well-done randomized trial.
Nancy put in a question just asking how is that possible in the sense that how could the families be blinded as to whether frenotomy was performed when you can visually see the difference?
Yes, indeed. So those would be the challenges of doing the randomized trial. But someone would have to sit down and think these issues through, where sham procedures have been done. So in this particular example where I gave you about the ischemic heart disease, so what they did was they randomized people to internal mammary artery dissection and insertion into the myocardium. Whereas in the control group, they opened the person's chest, they dissected the internal mammary artery, they ligated it, but they did not put it into the myocardium. Now that's an elaborate sham procedure, and it was justified ethically by saying that there were so many people who were receiving this treatment without us knowing whether it was efficacious or not. So the sham procedure was ethically justified, and they got it past their ethics boards, but this was a long time ago. Now, I'm not saying I know exactly how we would do the sham procedure for frenotomy, but with some thought given to this, I'm sure that there could be some way it could be done. I mean, there are studies done without blinding, but ideally we should have blinding, or we should have assessment of the change, post-change should be as objective as possible rather than a subjective judgment either from the mother or someone, or even a clinician who knows the status of the intervention.
Mona, just sort of to follow along that on this whole concept of the randomized controlled trial or the continuing study of this, Mona is suggesting that without a doubt there is a lack of research of adequate size and rigor to answer the question. But she says we also know in the research world not all questions can be studied with a randomized controlled trial, and that a multidisciplinary approach would add value to this question.
Surely a multidisciplinary approach would be very valuable and it would address some of this controversy, certainly. However, I think in my limited, in my experience, the clinical world tends to go with randomized trials for questions of efficacy. So if you are asking the question, does this drug work, or does this treatment or surgical option work, or does it not work, the gold standard tends to be the randomized trial, just in that very narrow area of efficacy. So there are definitely many areas of this issue, like for instance, the diagnosis of ankyloglossia. That's got nothing to do with, randomized trials are not going to help us there. So we have to come up with a standardized diagnosis through various other approaches. But just for efficacy, that's where we need the randomized trial.
Now, there are a number of sort of questions that are going to sort of stretch your clinical knowledge or start to approach that. So I'll try to keep away from too many of those. But there were a number of questions around just asking in general, what are the cons associated with conducting the frenotomy? Why are Canadian doctors generally against it? Are there risks associated with the frenotomy? And what is the reason that doctors feel frenotomy is not an easy, quick solution to any and or all cases of ankyloglossia?
Yes, that's an excellent question. So I think ankyloglossia, frenotomy for ankyloglossia is a very simple procedure and can be done very quickly. And it's very, very rare. There have been some very rare case reports of problems like excessive bleeding or whatever, but that's so rare. So it remains a very simple procedure. The reason why pediatricians are opposed is twofold. I think one is that historically, the pediatricians were the ones who were pro various procedures like tonsillectomy and ear tubes, and over time they've realized that these minor conditions, relatively minor conditions, resolve by themselves, and so it's not necessary to do something like surgery on a newborn child or a very small child. So there is over time, the pediatricians have become very conservative about surgical issues. That is probably one big reason. The other big reason is there is no evidence. So before you recommend any surgical procedure, small or large, you need to have the evidence in place to show that it is efficacious. So those would be the two major concerns that pediatricians have.
I'm just trying to go through. We have again, we still have quite a list of questions here. So maybe we'll take just a couple more before we start thinking about wrapping up. There's here's a comment from Joanna saying, is it possible that we as health professionals could use assessment skills and determine the best treatment options based on the evidence of clinical assessment and guidelines? But again, the lack of specific guidelines around this particular condition are not there, as we've sort of identified.
Yes, there is a lot of room for clinicians and researchers to come together over this issue, standardizing the diagnosis or using existing tools and validating them and seeing whether it, how effective these tools are, whether they in fact can predict breastfeeding problems or not, and issues like that.
Mm-hmm. One interesting question just came in. I mean, in your research, you presented sort of perspectives from pediatricians and lactation consultants, et cetera. Leah's asking, what's the role of dentists and or dental hygienists or the dental community as another key group in this issue? Are they part of the diagnostic procedure or identification of the issue or anything like that, typically?
Indeed, they are at a later stage. So post-discharge from the newborn period. So in the newborn period, they don't come in. But afterwards, I understand that frenotomies are being done in dental offices and the diagnosis of ankyloglossia is also being made in young children in dental offices. Yes, so that's the controversy would really be around issues related to ankyloglossia, frenotomy, and breastfeeding. So in the very early period, the dentists are part of this issue. Yes.
So this question from Nancy is just sort of asking. So you mentioned in your research that there could be two causes to the issue. It could be the promotion of the Healthy Baby Hospital Initiative and the increased focus on breastfeeding that's just causing us to notice this more versus an actual increase. She's sort of asking if there are any conclusions as to whether this increase is again from people just looking more closely, or if the condition is actually more common now. Do you have a sense or an opinion on which way you would lean on that?
Yes, my subjective sense is that given the wide variation in rates across provinces, I think it's got to do with looking more carefully now rather than it being a true increase. I've spoken with clinicians here as well in the BC Children's Hospital, Women's and Children's Hospital, and they have a much more conservative opinion on these issues. And so our rates are very low because they tend to question and very carefully assess the children before they suggest a frenotomy. So it seems to me that you have a conservative standpoint which gives rise to lower rates, and a less conservative standpoint which gives rise to higher rates. So it's likely that this is a surveillance issue that we have become sensitized because of our desire to increase breastfeeding rates, which of course is a very important thing to do.
So this is the last question I think we'll take, and then we'll give you a chance to sort of any key messages or closing comments you'd like to make. But Sonia's just sort of asking about the future of the research in this area. Do you have plans of continuing of doing a randomized controlled trial in this area? Like, is that in the works? Have the research grant applications been submitted? Are you working towards this now, or is that something that's just sort of not on the books right now?
So, each of us, we have a different specialization. So my work typically tends to be on the surveillance side. So we look to see this congenital anomaly or another congenital anomaly. So I don't typically do work related to randomized trials. But this particular Ankyloglossia issue is alive across the world. So there are so many countries where this is a big concern, and rates have risen elsewhere, although nobody's documented it as carefully as we have. But the controversy is very much alive in the UK, in other parts of Europe. So it's someone is going to do it soon, and I think Canada is a great place to do it. But because there are so much randomized trial expertise, people can come together and do this. And I'm sure that I would be happy to be part of such a randomized trial, but I don't typically tend to be to lead such trials.
It was like an opportunity for someone to get in touch with you and take a lead on this. So hopefully somebody will be in touch with a proposal at some point in the not too distant future. All right. So with that, we'll just anything you'd like to leave the audience with before we wrap up. Any final closing comments or key messages?
Yes, my closing comment would be this. I mean, in the way I presented what I did, I probably revealed some of my own biases. But the purpose of this presentation was really to sensitize people across the country to the controversy, and without necessarily saying this is the right answer, but that we need to find the correct answer through better research, and hopefully that will come soon.
It's a great way to end this off. So great comment. So thanks again for joining us. Great presentation. I mean, really, as we can see by the list of questions, that was it really did generate some controversy there. So we do our webinars usually every Wednesday at 11 a.m. Eastern Time. Just coming back from the conference, we don't have a full schedule for November, but certainly in December and even January, we do have our full regular Wednesday schedule. And it is great when you can watch live, because these questions and comments were really great and really help generate the discussion. But when you can't watch live, of course, we do record all of these sessions and make them available after the fact on the Knowledge Exchange Network. Our next webinar will be Thursday, November 24th, when we will be continuing our relatively new series, Life with a Preterm Baby, where we have partnered with the Canadian Premature Babies Foundation on a 6-part series that's aimed to provide information to parents of preterm infants, although this is also a great resource for health providers as well. We had a great turnout for our first 2 episodes, focused on the importance of movement for preterm babies and newborns. Our second episode about common winter illnesses that parents of preterm infants should be prepared for. And our next episode will be an introduction to neonatal follow-up clinics with Dr. Paige Church and Dr. Vincent Ho, who are experts in the field of neonatal follow-up. And they'll be explaining the vital role of neonatal follow-up clinics in helping NIC graduates achieve their full potential. And they'll also discuss how the world of follow-up itself is changing from a model based on data collection and surveillance to a more holistic model that considers family well-being and has a strengths-based approach. And we'd like to thank Prolacta Bioscience for their support in making that webinar series possible. Then on November 30th, Wednesday, we'll be back with our regular Wednesday episode with a session on mental health problems in children with neuromotor disabilities. This presentation is following the release of the Canadian Paediatric Society's position statement on mental health problems in children with neuromotor disabilities, and using the World Health Organization's international classification of function as a framework, our presenters will present cases and describe a comprehensive multidisciplinary approach to mental health symptoms in children with with neuromotor disabilities such as cerebral palsy, muscular dystrophy, and spina bifida. So a couple of really interesting presentations coming up this month. Thanks again for joining us today. Thanks to Dr. K.S. Joseph from BC Children's Hospital and the BC Children's Hospital Research Institute in Vancouver for joining us today, and we hope to see everyone back here for our next presentation. Bye, everyone.